so I don't forget. Good morning, everyone. If you're just joining, please don't forget to drop your name and your practice in the chat so that we can capture that for attendance. Morning, Bob.
Morning, Jana.
Good morning, Elizabeth. Times like this, I wish I had Chad to MC for us. He always keeps it, lively before the meetings get started.
It's a gift at any time, but it's 7:59 in the morning. I don't know if even Chad would have anything
I
exciting.
think so. I've got a lot of faith in him.
Well, good morning.
Morning. Gonna give it, there's still people joining pretty regularly, so I'm gonna give it probably a couple minutes after 8 before we get started, just to make sure that we are good. If you're just joining and you haven't heard this already, please remember to drop your name and your practice in the chat so that we can capture that for attendance. Want to make sure we are counting you as here. Good morning, Mark. Good morning, Elisa.
Good morning.
All right, we'll give it another minute or two. And then we'll get going there. Okay. Okay, I'm going to say it one more time before I start talking. If you just joined, please remember to put your name and your practice in the chat, especially if you're joining by phone. We won't know who that is, and we want to make sure that we're giving you credit for being here. So make sure you just drop your name and practice in the chat, please. All right, I think we're good to get started. Can everyone see my screen okay? Perfect. Okay, thank you guys for joining so much at 8 a.m. I am going to be your MC for today. Renee is on vacation and what I can only hope is sunny California, although they've been having bad weather, so it's me, and I hope she's staying warm. We do have a pretty packed agenda today. So I just want to make sure that we are staying on time and getting through stuff as we need to. So first, we're just going to start with a couple staff updates. I am affectionately calling this the dawn of the Kates. We have Katie Konecki. So Katie Konecki is going to be joining us. Well, she joined us in January from Common Ground Health. Katie is joining the data information management team, where she is going to be using her skills in project management and working with stakeholders to kind of help us with our data and population health initiatives. So she's going to be helping us a lot to optimize those value-based contracts that we have. So we are grateful to have Katie joining the team. Next up, we have Kate Sharma. So she's actually going to be, she joined our data optimization team last month as well, I think just a couple weeks after Katie. And she's going to be working with Elizabeth and her team, as well as the behavioral health integration team on depression screening and follow-up, as well as our collaborative care models. Elizabeth, I know you're on. Is there anything you'd like to add?
We're just really excited to have Kate. She joined us from the university, and she is a medical anthropologist by training. So has lots of really interesting insight into, how different groups of people work and why. And I'm really excited to have that lens as we dive a little bit further into this work.
Happy to have her on board. We also have Catherine or Katie Whiteman. So Katie joined just at the beginning of this week as the Director of Lactation Care Management. She's going to be presenting later on in the slide, but I did also want to just give an opportunity for Lisa to introduce Katie and her work. So Lisa, if you want to come off mute, you can definitely do that.
Wonderful. Thanks, Jana. Good morning, everyone. I'm so delighted to be able to introduce you to our friend, Katie Whiteman. Although she is just joining this week as an employee with AHP, we have had the joy and real pleasure of working with her over the last 4 years as we've supported and collaborated and sought to further a program that Katie herself conceived of. So just a little background, she has a master's in literacy, focusing on birth. She also has both experience and training in special education, both of which come into play in her work in the lactation care management program in Dansville. And our goal is to extend that work into the Jones Memorial and Allegheny County region. So thank you for the time to introduce Katie. Welcome to the practice managers meeting. And I won't tell you anything more about this wildly successful program and let her have a little fun with that later. So thanks.
No problem. Then just moving into network additions and departures. As you know, our network is constantly changing. So this year we are happy to have Our Lady of Lourdes down in Binghamton joining. That is really nice to see our network expanding in the way that it has. And we also added a number of dermatology practices last year through the end of the year. So we have 3 practices: Rochester Dermatologic Surgery, Flower City Dermatology, and Universal Dermatology that came on board. And that's going to be a big help for network members, for those folks covered under our contracted plans to have access to those specialties. Transitioning. So these people aren't really leaving AHP or joining AHP. Alexander Medical Group and Brighton Family Medicine both transitioned to URMC practices at the beginning of this year. So we are grateful for the time that they spent in the network as independent practices, but super happy that they are still going to be in the network and seeing our patients. Dr. Kerper, he retired at the end of 2022. He started with AHP in 2013. So it is, sad to see him go, but happy, that he's able to retire and enjoy his time, hopefully golfing or doing something leisurely. So that is what's going on with the network. I also just wanted to take a minute to talk about the 2023 meeting schedule. So this year, this practice managers meeting is normally held on a Wednesday, 4 times a year. This year, the meetings are not all on Wednesdays. However, they are still at 8 a.m. So we've got a June meeting, Tuesday, June 13th, Wednesday, September 20th, and then Thursday, December 14th. So please save those dates so that you are not looking at them for the first Wednesday of the quarter, because we want to make sure that you are able to attend. If you are ever looking, I want to make this special announcement. If you're ever looking to get into a meeting last minute, you don't have the link, the email's been deleted. I encourage you to please go on to our website at ahpnetwork.com/events. That is going to be the easiest way for you to get into our meetings quickly. And that goes the same if you're ever trying to help out a provider who is trying to join one of our meetings as well. That's going to be the best place, most efficient place for you to get into there quickly. So just a reminder on that. I don't have anything else right now, so I'm going to kick it off to Elizabeth Sharp, who's going to talk about our 2023 quality measures and our quality program.
Thanks, Jana. Good morning, everyone. Good to see you all. Wanted to take a moment to touch base about the quality program for this year. So Jana, if you could jump to the next slide. What you will see is extremely familiar. We are pulling forward from last year the same quality measures that we wanted to display. You'll notice every quality measure here has 10 points assigned to it. One thing that I wanted to call out, the well care visits in the first 30 months of life was a new combination, I'll say, last year. So the first 15 months, well child visits in the first 15 months is very familiar to everyone who works with pediatric patients. That 15 to 30 month is a new measure, or was new last year, but we need to take them both, the way that the quality measures are structured. And so what we're doing is offering that as a report only measure. You will be able to see your performance this year. And then next year, that will be a sort of a regular pay for performance measure, but we wanted to make sure that folks had enough runway to adjust to it, to make sure that the data is capturing appropriately, all of that stuff. So just to run through really quickly, on the adult side of things, we have diabetic care, both A1C less than 8 and eye exam. We have controlling high blood pressure, which is the new name for hypertensive blood pressure control, breast cancer and colon cancer screening, and fall risk management. And on the pediatric side of the house, we had childhood immunizations, adolescent immunizations, and then those 2 well care visits, the 0 to 15 and 15 to 30. Anyone have any questions about the grid? Hopefully this is all very familiar to you. All right, next slide. One thing that I did want to call out is on our website, and there's a link at the top because I know that Jana often sends out materials after these meetings, so I thought that might come in handy. We have a section on our website that has one-pagers, and these one-pagers give you the definition, the numerator, the denominator, highlight any changes, and show changes in thresholds for the different quartiles for all of our measures. So we wanted to make sure that you had an easy way that wasn't too technical, quite frankly, to access the definitions and what counts. So you can find some information on the site here. If you have any questions, please don't hesitate to reach out. I really don't mind getting emails about quality measures. Next. We are still working on our quality improvement initiative, depression screen and follow-up. What we're looking for here is that all patients ages 12 and up are screened for depression once a year, and that those patients that screen positive using a validated screening tool have an appropriate follow-up within 30 days. You have been hearing about this for years from us. In the interest of kind of aligning things with our quality grid, we are pulling forward what we worked on last year. So we do want to provide resources, provide support for that follow-up within 30 days. But what we're looking for from a performance perspective is a 15% increase in screening rates from the prior year up to 75%. If you're screening more than 75% of your patients, we love that. Please feel free to not reduce it to 75% of your patients. But we wanted to make sure that we're setting appropriate thresholds. We are using the HEDIS definition here in general to kind of map this, but didn't want to use the HEDIS quality measure in the grid. It's combined for screen and follow-up, which makes it a little bit challenging to get to the actionable patients. And we're not sure how comfortable we are with those thresholds yet. So wanted to make sure, again, that we're giving folks some runway. Next screen. We have a couple of different avenues to learn more about depression screening and engage with your data. I wanted to call out our depression toolkit. I see Daryl on the call. And so I always say that this is very snazzy looking, and Daryl says it has great clinical depth. But what we have on our website is sort of an interactive toolkit. It offers some crisis intervention resources, some recommendations for patient education, and then, let's be honest, the most popular piece is our pharmacy component. One of the things I wanted to call out about this toolkit is that there is separate information for adult and adolescents. Our pediatricians have found the adolescent medication management information particularly helpful based on the feedback that they give me. It's possible they're all being polite, but I think they really do like it. And then the provider engagement report. So you are all going to be hearing from me over the next couple of weeks and months about the provider engagement report. We want to make sure that folks are comfortable with how to navigate it and what data is available. And one of the things that we are communicating via the provider engagement report is the depression screen and follow-up. We have information about patients screened, of those screened who screened positive, and of those who screened positive who had an appropriate documented follow-up. So you'll be hearing from myself and from Kate. We want to make sure that you understand the data, that you feel confident in the data, and that we can kind of move forward from a more clinical perspective. So if anyone has any questions, please don't hesitate to reach out. But those are the two components, the quality grid and the depression initiative, that I wanted to touch on today. Back to you, Jana.
All right. If you have any questions for Elizabeth, again, you can email her, you can drop them in the chat, and we'll, get to you. Which this is a really good segue into the PCP reward plan and provider engagement report. This is another thing that folks have likely been hearing about for 2 years now. And so we're really excited to be making a lot of progress here. So if you remember, we introduced a new PCP reward plan that was effective beginning with last year's performance year. The goal of that is really to better align our network's incentives with our network's contractual accountability. So we've primarily focused on quality measures, but we do also have a cost component to our contract. So even if we provide the best quality, but we're doing that at a premium, we're not, being as efficacious as we can be. So we want to make sure that we are keeping cost in our purview. So we are going to be combining quality incentive payments and gain sharing payments under the new PCP reward plan. And what that means is there's going to be one payment in the year following the performance year. So for 2022, that payment is going to be made in September of 2023 for the 2022 performance year. The new provider engagement report is going to really be a tool that's going to help practice managers and providers demonstrate how they're progressing towards the incentive. As we've said before, we cannot tell you this is the dollar amount that you're going to get, because we don't know if we're going to make gain sharing. We're not sure if we are going, what that dollar amount is going to be if we make it. But what we can do is show you throughout the year, if the year was to end today, you're 50%, 75%, 90%, 100%, all the way there to earning your incentive. So what the new PCP reward plan looks like. This is going to vary based on your practice, practice type. So internal medicine, what we've got is our quality program is going to make up 75% of your PCP reward plan for providers. Cost saving initiatives is going to be another 15%, and then citizenship is 10%. So the cost saving initiative for internal medicine is pharmacy this year, and I'll talk about pharmacy briefly, and I'll also give Bob a chance to chime in if he'd like to. And that is going to be all about medication switches and engaging with the pharmacy team in making that good for your patients. Citizenship is going to be those types of things that you do to show that you are engaging with AHP. So being at this meeting is one way that you can show that at the practice level. So we want to make sure that we're encouraging behaviors that, encourage you to engage with us. So for the pharmacy component, that 15% for internal medicine, this is going to be, actually, Bob, I know I'm putting you on the spot, but would you like to talk about the pharmacy reward component of PCP reward plan? Since you're here. Did I miss some? Oh,
Sure, I'd be happy to. Sorry, I had trouble finding the mute button there. Yeah, so this year we've got 4 kind of initiatives. And again, it's all carrying forward from last year. Like we've been talking about kind of working with the system that's already in place. We know that last year was kind of rough with getting all the data. We're hoping this year will be a little bit better. So basically the 4 kind of plans is, Insulin Lispro, converting it to the biosimilar, same with a long-acting Lantus, converting that to the biosimilar as well. Metformin, is keeping that with a generic. And then there's a few NSAIDs. And what's very helpful with the PER this year is when you click on it, you'll be able to see it. You'll be able to see if what patients are opportunities for you to work with. If you have any questions, we're also here to help you with that.
Thanks, Bob.
No
I
problem.
know, I put him on the spot, but I'm like, I'm not going to talk about something that he knows better than I do. So moving forward to family medicine. So similar to internal medicine, there is the pharmacy component, but there's also the LARC component. So the long acting reversible contraception. So what you'll see is that the quality program makes up 60% of the PCP reward plan for family medicine providers. So what we've done here is we've taken that 15% from quality measures and redistributed it to LARC. So some of the things that are going to count for LARC are going to be attending a training. So if you went to any of our Dr. Phelps talks last year, that is going to count for LARC. And then there's going to be some additional opportunities for training throughout this year. Again, pharmacy, those things that Bob just spoke about are going to count for cost saving initiatives in this space as well. And again, citizenship is going to be maintained at 10% of the PCP reward plan for family medicine providers. In pediatrics, we don't expect you to have a lot of pharmacy switches that need to take place in the pediatric space. So again, we've moved that 15% back up to quality measures, and your cost saving initiative for 2023 is going to be LARC. Again, maintaining citizenship at 10%. So citizenship, you can qualify for citizenship at the practice or the individual provider level. Attaining this at the practice level is actually something that we would encourage and is easy to do. So things that count for the practice level component are, attending 2 or more practice managers meetings in the year, if your practice is participating in a pilot or an optimization program, if you are actively engaging with pharmacy around your pharmacy switches. Those are some of the things that we're talking about will allow you to hit this at the practice level. So if you do not attain citizenship at the practice level, which would count for all providers in the practice, there is still a way for providers to hit this at the individual level. So if there is a provider who is on an advisory committee, that counts if you attend those meetings. Accepting new patients, when we do this, when we calculate our reward plan, that will also count if you're accepting new patients at that point. A really easy one to grab is not unsubscribing from our email communications. If you're receiving our email communications, that's another thing that's going to count. And then if you are someone who is participating in the Vatica initiative, there's going to be thresholds for that will also count for attaining this at the individual level. So just some things to keep in mind as you're working out schedules for the year. And really how we are hoping to support the PCP reward plan is with the provider engagement report. We really want this to be a tool that's used in conjunction with Arcadia to give you insight into your holistic performance for AHP initiatives. So the PER is going to allow you to gauge and manage performance for providers throughout the year. It's going to give you a snapshot of your quality. So the quality measure component that's pulled into the PER does come out of Arcadia. But what you'll be able to do is see if you're, how you're performing. And then if there's something that prompts you to dig into Arcadia, you can go right into that system and pull your gap reports if you need to do that. It's also going to give information on total spends. So how are you doing in that cost component that we were just talking about? And then also, again, this progress towards your incentive. So we can't tell you how much, but we can tell you how close you are to getting full amount. This is going to be distributed electronically. We have been working throughout all of 2022 and still in 2023 to get providers, practice managers up on the PER. Going through that guest account process with Cherie Turpin, who is also on the call this morning to get folks up on the PER. So if you're having issues accessing the PER, if you have issues, if you thought that you were signed up for the PER, but you don't remember going through this process, you can definitely reach out to myself or Renee. And we can connect you with Cherie, or you can reach out to Cherie directly if you've got her contact information, and it will be at the end of this presentation. So that is the provider engagement report, the PCP reward plan. I want to just give a minute for any questions that folks might have before I jump into the next topic. See a couple of things in the chat. Okay, and before I move on, if you joined us a little later, please enter your name and your practice into the chat. I need to get like a banner that just kind of scrolls across while I'm speaking that says that. so I don't sound like a broken record, but please do that. Next up, we are going to have Dr. Daryl Sharp. And I believe LJ might chime in a little bit this morning about our trauma-informed primary care project. They're going to provide a nice update on what's going on with that project and how it's advancing. So I'm going to turn it over to Daryl. Oh, I see a hand up. Jen, how can I help you?
That was accidental. My apologies.
No, it's okay. I just wanted to make sure I didn't miss you. Okay, so I'm going to turn it over to Daryl and LJ.
Thank you, Jana. Good morning, everyone. So LJ and I are here to talk about a project that we've been working on with a number of you for the last 19 months or so. The other person who we've been working with is Kelly Luther, who is the Director of Social Work and Patient and Family Centered Services at the Medical Center. So go ahead, we can go to the next slide, please. So the purpose of this project is really to advance health equity by working with 5 practices across the AHP network and supporting those practices in delivering trauma-informed care with the idea of learning from the experience, doing a solid program evaluation, gleaning as much knowledge as we can from the pilot experience with the idea of thinking about how we might roll this out over the network more broadly. Next slide, please. So let's talk about what we mean by trauma-informed care. It's really a culture of care delivery that's really seeking to identify and to respond and to recognize the widespread impact of trauma and to prevent re-traumatization. And it really all began with some studies in the late 90s where it was established that adverse childhood experiences, things like children being exposed to violence, child abuse, divorce, mental illness in a parent, those kinds of things predicted adult onset of illness. And over time, that research has expanded and recognized more broadly other forms of trauma, such as racism, sexual identity concerns, etc. SAMHSA, Substance Abuse Mental Health Services Administration, that's what SAMHSA stands for, identifies 6 principles of trauma-informed care. First, care delivery that is psychologically and physically safe for patients and staff, that is characterized by transparency and trustworthiness, meaning that people feel like that they can trust what is being told to them by the care system they're getting care in. Peer support, which really speaks to the voices of patients in informing care delivery. Collaboration and mutuality is about making sure we minimize power differentials in the spaces where we deliver care, where we empower people, we give them choices, we recognize their strengths and their resilience, not only the fact that they've had trauma, but they also have protective factors and resilience factors that are important to recognize, and that we seek to eliminate biases and stereotypes based on race, ethnicity, gender, etc. So that's what we're talking about with trauma-informed care. So we can go to the next slide, please. And LJ, please chime in here. We've really been partners in this work. So, so here were the goals of the project. We worked with the 5 practices that you see there. Golisano Children's, Strong Internal Medicine, his branches, Stony Brook Peds, and Long Pond Pediatrics. So we had a wide variety of practices in terms of types of practices and also geographic location. We developed action plans for each of those practices to advance trauma-informed care. We've been piloting those. We have a process for evaluation, which we'll share with you. We've used a tool called Trust, and we're developing dissemination guidelines. We're trying to figure out how do we make this enlarge the circle and help others do this work. Next, please. So what we did, we established a learning collaborative, and one of the things that we asked each practice to do was to send a representative, that an administrative representative, as well as a clinical lead, to represent the practices in our learning collaborative. And it was important because a lot of the trauma work, oftentimes trainings, for example, and orienting the staff to trauma-informed work happens on the clinical side of things, but not the administrative side. And you really can't change culture unless everyone's at the table. So we really wanted to see both clinical and administrative teams at the table, and we've had that. We've had seven educational sessions. They're listed there in terms of the topics that all of the practices participated in. And then we've had monthly calls with the practice teams where we've really shared what's working in one practice versus another practice, what's challenging people, how can we share and learn from one another in terms of advancing this work. Next slide, please. These are some of the practice-initiated trauma-informed interventions. We've had de-escalation trainings in the practices that have been shared widely. Number of practices have established debriefing sessions and huddles, especially when you have critical incidents in the practices, case reviews, a lot of implicit bias and anti-racism training. Work that you do in the service of advancing health equity is trauma-informed by definition. We've done some work around managing difficult phone conversations, looking at screening for adverse childhood experiences and resilience screening in our workflows, looking at our policies, looking at things like no-show policies to make sure that they're trauma-informed, making sure our physical space is safe and perceived as welcoming and warm and inviting to patients and for staff, looking at hiring practices, and then also establishing patient advisory groups. So these are some of the kinds of things that people have done in the practices, just to give you a sense of the work. Anything you would add here, LJ?
Oh, Daryl, you're covering it beautifully.
Oh, all right, okay, thanks. Next slide, please. In order to see what kind of progress we've been making, we worked with a consulting group. Well, I should say we've been working with a consulting group. I should have said that at the outset. We didn't want to reinvent the wheel. And frankly, healthcare has been a little slow to the table in trauma-informed care. Elsewhere in the system, in our society, schools, for example, have been really working in the trauma-informed space for a long time. And on the behavioral health end of things, and in community-based organizations, a number of community-based behavioral health focused groups have done a lot of trauma-informed work for a long time. Our social work colleagues have been working in trauma-informed work for a long time. But we wanted to work with CCSI, which is Coordinated Care Services Incorporated. And it's a consulting group that has been in Rochester and working across the state, frankly, for the last 40 or 50 years, and has done a lot of work, especially in the schools, around implementing trauma-informed care practices and also measuring the impact of interventions that are trauma-informed in terms of what kind of impact that they've had. They recommended we use a tool that's been used widely across New York State. It's called the TRUST tool. That acronym, I'm just going to leave on the table. I can't remember exactly what it refers to, but it has a number of subsets of things that are important to focus on, like training, like perceptions of the safety of the environment, like perceptions of staff wellness. All of these things are part of trauma-informed care. How well engaged are your patients in their own care? Those kinds of things are all measured in the TRUST tool. And what we did is we administered that tool to the 5 practices in October of 21, and we repeated a follow-up just this last fall. And we intend to do focus groups with the 5 practices this spring. So let me show you what we learned from the TRUST tool data. So in the area of training and workforce development, specifically focused on what is trauma-informed care and how do you implement this? We saw movement in terms of that particular metric. And the next one, please. Staff wellness, we also saw movement, improvement in perceptions of staff wellness. And those two variables, training and wellness, were really where the practices wanted to start, because I want to remind you that we launched this in the pandemic and everyone had the same concerns, which had to do with the well-being of the workforce, given especially the stresses of the pandemic. So those two variables are where we saw the most movement across the project, which made sense to us because that's where we've spent most of our time, in wellness-focused initiatives and also in training teams on what is trauma-informed care and how do you implement it. Next slide, please. Physical environment, we also saw some improvement in this. When we're talking about physical environment, we're talking about perceptions of the staff on the physical and psychological safety of their care environments. Next slide, please. Screening, we saw some movement here, which was interesting because screening is complicated, not the least of which is you're all screening for lots of things already. So how do we add another screen without, you know, just from a burden perspective? But there's some debate about screening, but there's been a lot of interest in, if you're going to respond to trauma, you need to know what's the nature of trauma people are experiencing. So there has been some movement in that. And then the next slide, please. And then perceived, and these are staff perceptions of the perceived engagement and involvement of patients in their own care delivery. So remember all those principles of trauma-informed care. You're picking up this notion of how involved are the patients in care. That's really important. Next slide. So just in terms of preliminary conclusions, the big thing was we've seen movement in the proper direction, in the direction we would hope anyway, understanding that this is a program evaluation. We can't say for sure it was this grant initiative that moved the needle on that, on all those metrics. But the fact that they're trending in the positive direction and the fact that we saw movement, most movement in the places where we spent most time, gives us some confidence that the project has been well received and we've been effective. Other things that I think are important is, you know, just we know the importance of sort of the full leadership team in being on board with trauma-informed care, the importance of that. We know that when practices have access to behavioral health supports and quality improvement supports, they're more able to move in this space as well. We know that there are some differences. Our BIPOC respondents, Black, Indigenous, people of color respondents, for example, perceive the physical environment and as less safe than our white respondents. And we're still trying to figure out, okay, we're still drilling down into those data. But the feedback from the participants and anybody who's been part of the project, if you have any comments, we would welcome them. Basically, folks have told us that the project has been helpful to them in the sense of it's been nourishing. One of the principles that we said at the beginning, especially because we were launching in the pandemic, if this project couldn't be just another thing that people had to do, it needed to nourish the people who were participating in it. So we met people where they were, and there was no judgment. You are where you are. You're making progress in the places you can make. And if you're not making progress, there are good reasons why, and we'll support you and try to figure out how to help you. We essentially provided a trauma-informed response for the participants in this project. And I think that's been really important. So I think that might be the last, oh, maybe one more slide in terms of what's left to do. So the project ends at the end of June. The video series that you see there, we have been developing a toolkit that will be available to anybody in AHP to use. We have some short videos that teams can use to introduce notions of trauma-informed care with their practices. We're going to finalize that toolkit, and we're really trying to strategize at this point. Part of it is speaking with all of you and with other groups about ideas about how to move forward from here and roll this out and make it more available to practices that are interested across our entire network. So I think the last slide is really, what do you think? Any thoughts that you might have, any questions you might have? We really want to hear your thoughts and feedback because, as I said, we're trying to figure out how do we move forward from here.
Yeah, and I saw LJ came off of mute. LJ, is there something you wanted to add?
No, I just wanted to say to folks, I
realize there's other items on the agenda today. So we welcome your feedback in this space through email, reach out to Daryl and I, or to have a conversation. And we're going to come back to you again. I think as I think about all of you sitting here and how important this is in your support for your teams, that was the thing that really came to us, is like this is something that's really meaningful for our practice teams at a time where you all have experienced significant trauma and your patients have experienced significant trauma. So we really look forward to thinking more with you and then bringing you back what will be the sort of the portable and supportive reach out to your practices with this work in the future. Thanks.
If I could just add, one of the key words that Daryl said was nourish, and she did some training with her and his board, did some training with the pharmacist. And, we on the outset, I just, would you do a couple of trainings, because trauma-informed care is really not something that's akin to pharmacist training and a standard thing. And, so they did a couple, and my staff just loved it. They ate it up, and it really helped them in their practice. And when they asked to extend it and do a few more, and so they have. So it is such a great training for our staff and really feeds them.
Thank you, Bob. It's been wonderful to work with your team and with you. Thank you. Thanks, everybody. Really appreciate the time and your interest.
Thank you, Daryl and LJ. And yeah, if you have any questions, comments about that, please reach out. And again, we'll get you connected. So moving into something that is equally important in our world is we're going to be reintroducing Katie Whiteman to come and talk about the breastfeeding lactation program and its recent expansion. Maternal child health, parent-child health is something that is a buzzword, but Katie has been doing a lot of work in this space and really putting the work in to make things better for parents and their kids. So I'm going to turn it over to Katie. Katie, just let me know how you want me to advance your slides, okay?
All righty, thank you. So I did change the order of them, and I'll tell you when I get there, when I want you to change the order. I ran through this a couple of times, and those of you who know me know that once I get warmed up to this topic, it's hard to stop me. So I had to change the order a little bit so I could stay within my time frame. But as Elisa mentioned when she was introducing me, I've worked with Accountable Health Partners for the last 4 years, building and running the lactation care management program at Noyes Hospital in Dansville. So lactation care management as a concept and as a program is something that I designed with Accountable Health Partners and our local providers, hospital, and patients here in the Noyes community to address some significant barriers to appropriate lactation care that were faced by this community. And as we were beginning to build that, when we were looking at the state of lactation care and human milk feeding in 2017 and 2018, when we were starting this conversation, we found that our practices that were caring for parents and young children were supporting lactation care without resources, right? So this program is not just for supporting patients, it's also for supporting providers and practices who care for families with young children. So breastfeeding initiation and chest feeding initiation and duration rates are lower in rural populations, impoverished populations, and marginalized populations because of the additional barriers to care that are experienced by these groups. So access to care has been challenging for all, lactation care has been challenging for all populations for at least the last 30 years. So when we're taking on this problem, we started with one of the highest needs populations in our network. And that meant we needed to do some real innovation and teamwork to get this started. Can you go 2 slides ahead for me? There we go. That's the one I want. Perfect. So this program build really blended the principles of lactation care, which looks at the health of the whole dyad, with the principles of care management, right? So when we have a parent and child, and we're talking about human milk feeding, they're really a team that makes human milk feeding happen together. And they're in a symbiotic relationship that supports one another's health. So we have to look at both of them if we're going to look at either one of them, right? So the hormones of lactation are protecting the parent. The milk is protecting the child. Everyone wants that to work out. And our healthcare system is not designed for dyads, right? So we needed to come up with a program that was going to be designed for dyads and help our healthcare system support the health of the whole dyad. So care management does that, right? Care management looks at patients and families and communities and builds connectivity within healthcare systems that's going to allow for that full dyad care. So we were looking at building connectivity between obstetrics, the hospital, pediatrics, and then community and home settings, right? So our patients, when they are enrolling in this program, are enrolling in their 3rd trimester of pregnancy, and we're helping them to set up for success for their feeding goals. We follow them into the hospital. We continue to work with the whole healthcare team, making a plan that takes care of the needs of the whole dyad. And we help families transition home and into pediatric spaces, and then into community programs that support breastfeeding and chest feeding. At each of our contacts, we're doing screening for risk factors for premature weaning. We're coaching families on overcoming their specific barriers to their goals, if they have them. Sometimes things are easy, but not always. And then we're also connecting them with the resources in the community, and we're doing a lot of communication with the whole healthcare team, right? Because traditionally, obstetrics and pediatrics are not communicating with each other, right? But they're handing off breastfeeding and chest feeding care from one to another. So our lactation care managers are moving through the system with patients and helping that connectivity happen. And providers and patients both really like this, this program. Can we go back 1 slide, please, Gina? Okay, so I want to talk a little bit about our program results. So this slide is showing our data. What this slide doesn't show, except maybe that enthusiastic little face in the corner kind of gives a voice to it, but the way that providers and patients react to this program, all the time I get compliments and just joyful interactions with the providers that participate in this program about how much they appreciate that AHP brought this to them and kept it available throughout the pandemic. So if we take a look at the larger chart here, this is showing the breastfeeding and chest feeding rates in our local population in the year prior to the program starting. So this would have been 2018. And then at the end of the first year of the program, the breastfeeding and chest feeding rates in the program, and then in the end of the 3rd year of the program. So you can see there's about a 30% increase in breastfeeding rates at 3 and 6 months. And where it says EBF, that stands for exclusive breastfeeding. Where it says any, that means there's combination feeding some breast milk and some formula. And then the smaller chart to the side compares our program results to the general population of New York State from the CDC report card. So our third year, the end of our third year of our program was in 2022. The CDC report card is 2022. So we're comparing from the same time period there. Let's see, I think that was everything I wanted to say about that slide. So we're going to go ahead 2 slides, okay? So I want to talk a little bit about our expansion that we're working on for URMC Jones. This is something that the community at Jones has been requesting for quite some time, and it's something that we've been working toward. And we have recently received our grant funding for this, and we're getting started with this program build. And we're looking to establish a similar program. It won't be exactly the same because Jones isn't the same hospital as Noyes. So we're looking to use the model that we have built at Noyes and expand to Jones, building on what is available in that community, building for the needs of the providers, the practices, and the patients in that community. And as we do that, we're going to be learning more about the adaptability of the model. We already know that this model is pandemic proof. This model was built before the pandemic started and remained fully functional through the entire pandemic when all of our other lactation supports in this community were either completely gone or mostly shut down through the pandemic. And this program stayed fully operational. I'm so proud of that and so grateful to AHP for that support, and the community here is as well. So we know that there's adaptability in the model. We need to learn as we go about adapting this to a new hospital system and a new culture. And I think this is going to put us in a good place for exploring ways that we can use this model to support child family health throughout the network. And then my last slide is my contact information, because I know that I'm new to most of you. So if you're looking to get in touch with me, that's my contact information. And I wanted to open it up to some questions if we have time for questions. I know that some of you I've talked to about this quite a bit, so I was trying to kind of thread the needle between over-explaining to folks who I've already talked to about this a lot, and I didn't want to under-explain to folks that this is new for. So if this is new for you and you think I went a little fast, please ask for clarity. And if this is not new for you, but there's something you'd like me to talk more about, I think I have enough time that we can do that, right, Jana?
You sure do. I'll just start by saying, if any of your providers were at clinical grand rounds last year in the pediatric space, Katie also did a similar presentation to that group, and there was lots of great feedback there. And I know AHP is grateful for the work, and like Katie said, the community is just super, super happy to have this type of resource, and I'm happy it's going to continue. If you have any questions for Katie, feel free to drop in the chat, come off of mute.
I think that one thing that is popular about this program with both patients and providers is that really unfairly, I think, nurses and doctors and advanced practice practitioners really don't receive much training and education on lactation support. Everyone's expected to do it and miraculously know how to be great at that. And only lactation consultants are trained how to do it, right? And I think traditionally lactation care has been relatively isolated from the rest of healthcare. And that's where this model, where we are blending care management and lactation care together and really bringing lactation onto the team, is so helpful to providers. I've had many, many providers say to me, I did not have any idea what you do. And I can't believe we did this before without this program. So it's been really wonderful, not only to hear that, obviously it's very validating, but it's also been really great to see sort of the lifting of that burden from providers and the relief for patients, because the majority of this care is really taking place in regularly scheduled visits. The ask for this is really small in terms of what providers need to give and what patients need to give in order for this to work really well. So we're not asking patients to go to a different office or to another appointment. We're not asking them to set up transportation or deal with costs for any of those things. And we're helping providers to offer better care, expert care in a field that they have not been trained to offer expert care in themselves. And while the lactation care manager is handling those things, the provider can be doing other important work that needs to be done for the care of that dyad and other patients in their practice. So it really is a well-designed model that sort of just flows right into the gaps that have been there for a long time and shores that up without asking for a lot of extra work to be done.
Well, I'm not seeing any questions come into the chat. These slides will go out, so you'll have Katie's contact information and the slides if you want to reach out to her that way. Thank you so much, Katie, for joining this morning and in your first week with us. I know you've been around for a long time, but I appreciate you taking the time out of your first busy week to join us. Really do.
I am
Thank you.
pleased to have been invited. Thank you.
Okay. So we are coming towards the tail end of our meeting here, but I do just have a couple more notes to consider. Upcoming incentive payments. So we are looking that fourth quarter of 2022 clinical integration dollars will be paid out later this month. That is the goal, assuming that we get all the reporting data that we need to do that. And of course, we will send out emails and or paper checks if, however you've decided to set that up for your practice. Again, 2022 gain sharing is going to be paid out in September of this year. So if you have any questions on those two things, you can reach out to myself or Renee. We do like to open this up for open discussion. We've got a few minutes here. And before I do that, I do just want to mention a couple of resources that are available to folks. We have Well-Child roadmaps. These are those Candyland roadmaps that Elizabeth likes to call them. They're really good for pediatric and family medicine practices that really just underscore the importance of well-child checks, comprehensive screening in those first years of life. A lot of folks have put those in welcome packages for their new parents and new families. So if you're looking for those, reach out to me and I can get some out. Renee also sent out an email about the MCMS survey on physician wellness. If that's something that you think your providers are interested in, please go ahead and forward that to them. We also have a number of PPE left in the office. At one point, AHP was the PPE store. And so we do have some disposable N95 respirators. We also have some reusable respirators and filters, goggles, a whole mess of stuff. So if you're interested in maybe seeing what we have, hearing what we have, please just give me a call or send me an email. We can chat about what we have and what you might want to take away. We really don't want to see it go to waste, but it's taken up a lot of space in AHP now for, I think, the third year. So we're looking to start clearing out our house. And then to open it up to discussion, something to consider is we really do want this to be a space that's engaging for practice managers. If you have any topics that you think would be really great to discuss among your peers, we're always interested in hearing that. Send those along to myself or Renee, and we can definitely talk about putting those on a future agenda. Does anyone have anything that they'd like to discuss right now, bring up in the group? Drop it in the chat. I'm off of mute. Whoops, clicking through stuff. Okay, well, I'm not seeing anything come through. Reminder, next practice managers meeting is gonna be that Wednesday, June 8th meeting. So, you know, put it on your calendar. Make sure that you have your Zoom links from our website and other reminders. Yes, you're an AHP practice. Please refer to AHP specialists when you can, admit to AHP hospitals, and send to AHP imaging and labs. This is the way that those members in contracted health plans that we talked about in our December 2022 meeting for the University of Rochester, Highland Hospital, and Thompson get the most out of their benefits. So whenever possible, try and keep those folks in network. If you need any door clings, if you need help finding a specialist in imaging lab, please reach out and we can definitely do that. We will be sharing contact information for some of the folks that were mentioned or spoke today. And then additionally, those contacts for RMS Healthcare for PCMH Consulting, Medline, and Atlantic Health Partners. So with that, I'll give people back the 3 minutes that's left in this meeting schedule. But I will be on for a second if anyone has any questions. All right. Have a good day,
Jana,
folks.
Jana, just real quick, when the meeting for June should be the 7th, not the 8th.
Sorry about that. I think it's supposed to be a Thursday. I'll make that correction when I send out the slides.
Okay, thank
Thanks
you.
for catching that, Jerry.
Yeah.